Medicine, board certified internal medicine in hospice and palliative medicine, senior hospice medical director at MJHS and palliative care. He's going to help educate us on the kosher way of hospice and palliative medicine.
Good afternoon, everyone. So first and foremost, I just want to talk a little bit about a healthcare proxy, okay? The law allows us, of course we can make our own decisions, God forbid if we're ever in a situation where medical decisions need to be made. There could be certain situations and circumstances where, God forbid, a person is unable to make their own decisions, either from a permanent standpoint or a temporary standpoint. So the law allows everyone to designate a healthcare proxy, which is basically a surrogate decision maker appointed by the patient, must be by the patient. No one can become the proxy unless the patient appoints them to be a proxy, which basically means the patient has to be of sound mind and body and able to make certain decisions in order to appoint a person their proxy. And once that happens, there's a document that's filled out called the healthcare proxy. And if anybody's interested, there are these small little cards over here that actually have the healthcare proxy on them, okay? And that basically says who is going to make decisions for the person should they be unable to make their own medical decisions, either temporarily or permanently. It allows you to then put a secondary proxy. This way, if the first proxy either is out of the country or not available, or God forbid has died, who would be a second proxy that could make decisions for you. It allows there to be some optional instructions regarding certain things, which I'll talk about that in a moment. And then there's an expiration whether or not the healthcare proxy expires. If there's nothing else people get out of this, I can't stress enough the importance of having a healthcare proxy. Anyone who's above the age of 18 years old should have a healthcare proxy. Someone who's below the age of 18 years old doesn't need a healthcare proxy unless they're an emancipated minor, because they have parents who are going to make decisions for them. But anyone who's above the age of 18 years old should have a healthcare proxy. It becomes especially important given certain family dynamics. For instance, if imagine there's a couple and they've separated, and for financial reasons they've remained married. But they don't get along and they don't talk, okay? According to the law, the decision maker is going to be the spouse. So if the people are legally married, that decision maker will be a spouse. That may not be the person you want to be making medical decisions for you, especially if you are unable to, for whatever reason, maintain a relationship with that individual. There are situations where you have a frum patient and they have non-frum children, or vice versa. You'll have a non-frum patient and they have frum children. And the goal of the proxy is to act on behalf of the patient, and that's very, very important. We see that very, very commonly. Someone will come with a proxy document and say, I want this, I want this, I don't want this, I don't want this. And then after I listen, of course, because I want to be cooperative, I'll say, really, I can't really hear what you want. It's not up to what you want. You have to be telling me what the patient would want under the circumstances. And that's really what a surrogate is. If there is no healthcare proxy, then there's a certain hierarchy. There's a certain that the law put into place that allows there to be various decision makers. But the best thing is really to have a healthcare proxy. When I did internal medicine for about 15 years, I did an experiment in my practice for a couple of years where I wanted to see how many of my patients would be willing to appoint a healthcare proxy. 95% of them were willing to appoint a healthcare proxy, and they did it at my office. So when the patient would show up at the hospital, I had it on my computer, I would be able to fax to the hospital the healthcare proxy, and this came out of nowhere. And often in these types of circumstances, there's a lot of unpleasantness and things that are done for patients or not for patients based on the absence of a healthcare proxy. Very, very important document to have for everyone to fill one out. And then the most important part about the proxy really is the conversation. It's very important that the person who's your proxy, get to know how you think about medical care. What kind of things you'd want to have done, what kind of things you wouldn't have done, and especially if you're from, who is the rabbinical decisor, the posek, that's going to be answering halachic shilas for you? And there is a room to put that on the healthcare proxy. Often the poskim will not necessarily want to be the proxy themselves, but you can specifically write instructions in the option instructions to guide the proxy to make decisions based on this posek. And often, you can imagine you have children, some of them are on one side of the fence, some of them on the other side of the fence, even in the frum world. This one relies on this posek, this one relies on this posek, for this one, this posek is an apikoros, for this one, this posek is an apikoros. Creates a lot of family dynamics and a lot of drama that is really not needed in caring for patients. So on the healthcare proxy, it's also very important to denote who would be the halachic decisor should there be questions that are asked. Even if you appoint your local rabbi, you want to find out if your rabbi is willing to take that role. Even if you appoint your local rabbi, often the rabbi will then be consulting, because most local rabbis, unless they have special expertise in this area, are not going to necessarily be involved in the direct decision making. They're going to be asking somebody else. But you want to find someone, a rabbi that you trust, someone who's going to come visit you when you are in the hospital or wherever you might be. These decisions really should be made often with the rabbinical person coming to see the patient. So really a local rabbi is a very good choice. And then just to make sure that your hashkafa and their hashkafa is the same, otherwise why would they be a rabbi if it's not? And to make sure that your rav is going to ask an appropriate shalah to an appropriate posek. I can't tell you how much difficulties there are in dealing with what I deal with all these kinds of dynamics in non-Jewish patients, and in Jewish patients, and especially in frum patients. So healthcare proxy, very important, and have a clear discussion with your proxy with regard to what your wishes are, what you would want to have done, what you wouldn't want to have done. Yes, you have a question?
Is there any discussion to have other than who the posek is?
Sure. For example, okay? Do not resuscitate order. Under what circumstances would the patient want a DNR? Or what circumstance would the patient not want a DNR? Intubation, putting a patient on a ventilator. Under what circumstances would the person want to be put on a ventilator? Under what circumstances would they not? It seems like a... Oh, yeah, okay. So that's why it's good you're here. Very good you're here, okay? So let's put it this way. Again, I'm not going to be making halachic decisions. That's for the rabbis to do. I don't stick my nose in their business. My job is to present them with the mitziyut, with the reality of the situation, so they can make the decision based on the halacha. But let's just talk freely, okay? Generally, any person who is healthy, if God forbid they got an illness and they could potentially return back to a quality of life or a quantity of life like they had before they got sick, halakhically you are obligated to accept any and all treatment in order to get you back to where you were before. There's no question about that. Of course, if you don't want to follow the halacha in that circumstance, you can put that on your proxy, okay? But really where the questions become much more complicated is when the person, God forbid, has a terminal illness. When the person is coming to the end of life, then there's an ability within the halacha, again, you can speak to your rabbi, there's an ability within the halacha to say, I don't want that type of treatment for a certain reason. And there is a dispensation amongst the poskim that allows that under certain circumstances for a person to refuse various medical treatment. Almost all of these patients are what we would call chaye sha'ah, which means they have a limited life expectancy. According to many, it's less than a year. That would be considered to be chaye sha'ah. Others have a more stringent view of that. Again, I'm not going to step into that area. But when a person has a limited life expectancy, whatever that limitation is, there's a certain allowance for not accepting treatments that can either increase suffering or increase a life of suffering. Things like dialysis, things like transplants and things like that. These are the kind of things that really need to be discussed with a halachic advisor. So really, the healthcare proxy, you're not going to deal with every situation. You can't, because nobody knows unless you're a prophet. And we know what the Talmud says about people who think they're prophets today, okay? Unless you're a prophet, you can't know what's going to happen in the future. But the person has to get a feel of how you think about things. And it's so difficult when there has been no discussion. There's a proxy document filled out. Maybe the proxy knew they were, maybe they don't know they are. And now they're called to make decisions regarding someone they love dearly, and they've never had a conversation with the person. These are very difficult things to decide. Okay? And that's why, again, these are not easy conversations. These are not, we just finished Thanksgiving, so you have to wait till the next Thanksgiving. You want to have another one of those kind of things. These are not easy conversations to have, okay? You're not going to discuss it in Rosh Hashanah. You're not going to discuss it in Yom Tov. You have to find the Yom Tov that's not a Yom Tov, okay? That's why I picked Thanksgiving. But you want to have a discussion, and it's very important for that proxy to have an understanding of how you want things to be done, okay? All right. That being said, I'll add on, there's something called a MOLST form, Medical Orders for Life-Sustaining Treatment. You can Google NYS, New York State, MOLST, MOLST. That form, it's not perfect, but it's pretty good. That form is geared towards patients that do have a limited life expectancy, okay? And basically is a guide for the discussion between a person and their proxy regarding the types of issues that can come up, like feeding tubes, like IV fluids, like IV antibiotics, like hospitalization, okay? And that MOLST form. Now, okay, this is a very good conversation to have in the presence of a physician, okay? And the reason for that is, especially when there's a life-limiting medical illness going on, what the patient's prognosis is. Well, what is a ventilator? What is a ventilator? What is a feeding tube? How is that put in? These are the kind of things that really a physician should be involved in this discussion. And as far as Medicare is concerned, as of January of 2016, there's a specific code that a physician is allowed to bill for, any physician, basically for what we call a goals of care discussion, advanced care planning, where a patient will come in with their healthcare proxy or proxies, okay? And the physician can guide the discussion about the issues that could come at hand. Okay, that's called a MOLST form, M-O-L-S-T. That form, MOLST form, is active everywhere in New York State. It's actually honored outside the state as well, but I don't know that 100%. But in New York State, whether you're in a nursing home, you're in a hospital, you're in a ball game with the Mets, watching the Mets, and you have your proxy, you have your MOLST form with you. I'm not sure why you would have that, but anyway, it's active anywhere. And what ambulance EMS people are trained to do is the first place when they come into the house after they look and see what's going on is they look at the refrigerator and they see is there a shocking pink form called a MOLST form on there. And that helps to guide what the patient's goals of care are. Okay? Often in situations when you have an elderly person at home and there's a 24-hour aid that's provided by the city, they panic. They're not family. Someone starts having shortness of breath. The family understands that the goal is to make sure patients are comfortable in that circumstance, okay? Of course, after speaking with their rabbi. But the aide panics and calls 911. If there's no MOLST form on the refrigerator, that person's going to the hospital. There's no way to shut off the machine once it's turned on. Okay? I don't mean ventilator. That's a whole separate question. That's not what I meant. I meant that the medical machine, sometimes, in palliative care, and I'm sure my colleague can say, sometimes the train is moving with like 100 cars at 50 miles an hour. And I feel like I'm Mr. Incredible, holding the train, say, wait a minute, let's talk about this for a second, as the train is moving forward. And sometimes it's a matter of stepping back and reevaluating. A decision that was made 2 months ago may not be the right decision 2 months later. Okay, and that doesn't mean one has to change the decision, but to reevaluate all the items that involved in that decision from 2 months ago, which may not be appropriate at this point. Okay. I want to talk a little bit about palliative care in New York State. New York State took the bull by the horns, and basically in 2 years, so I think one in 2010 and one in 2011, they passed 2 laws. One is called the Palliative Care Information Act, and one is called the Palliative Care Access Act. The Palliative Care Information Act, basically, once a patient is diagnosed with a terminal illness, which in the medical parlance, potentially not like the halachic parlance, in the medical parlance is a prognosis of 6 months or less. Don't ask me where they get 6 months from. It's arbitrary. It's not based on any studies. It's a coverage situation under Medicare. So basically, 6 months or less, a patient is considered to be terminal. And in that situation, a physician or all the physicians caring for the patient or nurse practitioners are required under New York state law to have a goals of care discussion with the patient and or their proxy or surrogate, presenting all options for treatment, whether those options of treatment be curative treatment or whether those options for treatment be palliative care and or hospice. The key here is, as physicians, it is not our job to tell the patient or the family what the goals of care are. Okay? We happen to be in Queens, which is arguably the most culturally diverse area in the world. Okay? It's not my place to tell someone, whether they're part of my culture or not part of my culture, what their goals are. It is my job as a physician to develop a plan of care in line with the goals of care of the patient as said by the proxy and or the surrogate. If you are having a meeting with a palliative care person and they are telling you what the goals of care are, you can respectfully say, thank you very much. I appreciate your opinion. I just want to tell you what our goals of care are, and you tell us what the options are for the plan of care based on our goals. Okay? Trust me, I know my colleagues, present company excluded. I know what I'm talking about. Okay? So we should not be telling you what should be done. In a situation where a patient or family says, well, what would you do if this was your father or mother? A good physician will qualify that by saying, well, this is not my father or mother. If this was my father or mother, I would not be their doctor. I would be their proxy, but I wouldn't be their doctor. So it's a compromise type of situation, okay? But then I can give an answer based on that, okay? So that's the Palliative Care Information Act, and the Palliative Care Access Act basically forces all nursing homes, hospitals, certified home health agencies, adult homes, senior living, to have access for the patients that they're caring for palliative care, okay? The Access Act does not mention terminality at all. Anybody have any questions on that? There is not a hospital in New York State, and most nursing homes, okay, that you should not be able to, if you ask, say, I would like to speak with a palliative care physician. And I'll tell you how that adds help to the care of the patient. First of all, let's understand, what is palliative care? It's really, if we had to reinvent the term, we would probably pick something else. Just like internist, for many years, we couldn't figure out, we wanted to change the term for internist because people don't know what an internist is. What, you look inside me? No, I'm a doctor for adults. Anyway, we'll leave that alone. What is palliative care? Palliative care comes from the word in Latin, it means to palliate, which means to reduce suffering. Now, suffering comes in lots of flavors. Suffering comes from a medical point of view: pain, shortness of breath, anxiety, nausea, vomiting, diarrhea. Suffering can be spiritual suffering. A person who is, shall we say, believes in God and lived a good life, at least from what they think is a good life, okay? Then, of course, they get stuck with some type of illness and they say, why me? Or you have family members that will say, why my mother? Why my father? Okay? So there's a level of spiritual suffering. There's also social suffering. You can imagine a woman, she has a child that's, 14 years old, and she has a prognosis of less than 6 months. She's not married, or her husband is no longer around. Who's going to care for the child when she dies? If we don't think that that's suffering for that patient, we're missing the boat, because that patient is certainly concerned about what's going to happen to their child after they're no longer able to care for that child. So palliative care is an interdisciplinary approach in the ideal world, an interdisciplinary approach involving a physician, nurse practitioner, nursing, social work, pastoral care, volunteers, which basically meet together with the patient and or their surrogate, first and foremost, to review how the patient is suffering and to see what can be done to mitigate that suffering based on the individual practitioners that are involved with that meeting's expertise. You really can't communicate with a family and a patient about goals of care when they got their eyes twisted because they have pain 10 out of 10. The first thing you have to do is you have to deal with the symptoms. And if dealing with the symptoms means you have to talk to the family and convince them why dealing with the symptoms is important, then you have to do that. But you must deal with the symptoms first, because a person who's suffering, it's almost criminal to talk about goals of care when there's someone suffering in the bed. I think any practitioner that's doing that is missing their calling, and they should find something else to do. That's palliative care. Any questions on that?
I disagree.
What?
Yeah.
You don't disagree, do you?
No.
Okay, good. I hope not. If you disagree, it's okay. Okay? Palliative care is expertise. Now, all physicians can provide some level of palliative care. I'll tell you what I mean by that. Person goes to the orthopedist. They need some kind of a surgical procedure. The orthopedist gives you a prescription for some pain medication for a couple of days until the wound is healing, getting better. That orthopedist is practicing palliative care, what we would call generalist level palliative care. You're a regular physician when you go to their office. If you have a backache, you have sciatica, and they give you they recommend you to take certain medications for the pain. That's palliative care. So what is the specialty of palliative care? The specialty of palliative care is a physician or a nurse practitioner that has special training, advanced training in symptom management, okay? So where the primary physician can no longer go beyond that point, palliative care can pick it up and go beyond that point. Most physicians have a modest training in symptom management, okay? So therefore, they may be uncomfortable increasing the medication when it's needed, or they may not have the expertise to know how to use the medications, how to use the doses of the medication to avoid side effects and yet maximize the patient's comfort. That's where palliative care comes in as a specialty. As a specialty in medicine, it's unique amongst all other specialties. Because if I want to be a cardiologist, I first got to go to medical school. Then I got to go do a residency in internal medicine for 3 years. And then I got to do a fellowship in cardiology for 4 years. If I decided when I was a resident that I wanted to be a surgeon, if I'm doing internal medicine, I got to again do a surgical residency and then go do into surgical specialty. Okay? Palliative care has 10 different boards that lead to palliative care. I'll just name a few of them. Internal medicine, family practice, emergency medicine, OBGYN, pediatrics, psychiatry, neurology. Okay? That's just to name a few. So palliative care physicians can come from various different levels of baseline training in medicine. Okay? Palliative care is a board certification. It's a specialty of medicine since 2008. Like any other specialty. My favorite thing when I hear in the hospital or in a nursing home is the patient or the family is not ready for palliative care. Tell me, what does that mean? They want to suffer?
They think that if I hire someone whose specialty is palliative care, I'm admitting that he's dying and I'm not trying to cure him anymore. That's what the
Okay, so let me give everybody a news flash in this room.
Right.
They're correlating it to hospice, and they're saying that means that
The day, here's the news flash.
The only time I've been calling palliative care was have the conversation.
Okay, the day you're born is one day closer to being gone. Do we understand that? Which means, and of course, you know, Avraham Zaken Ba Bayamim, and Abraham was old and coming in the days, right? What does it mean he was Zaken? He became old, which means this was a first-time thing to have the ability on the outside to realize one is getting old and coming to the end of days. We don't like to talk about it, especially in this country, whether we're Jewish or whether we're not Jewish. We don't like to talk about it. We have a death phobia. And I'm going to tell you why that's very counterproductive in a very short period of time, okay? So we want to make sure that if the patient is suffering, pain, shortness of breath, nausea, vomiting, and the regular medical team is unable to manage those symptoms, that would be a time to think about involving palliative care, okay? Now, palliative care comes with another flavor, and that's expertise in communication. Newsflash. Not every physician has expertise in communication. It would be nice if we did, but many don't. I can't understand a palliative care physician not having expertise in communication. I've only met one, okay? Meaning we have to be able to communicate with patients and our families some of the most sensitive and difficult things to talk about in a very sensitive way. We don't want to take away hope, but we also want to be realistic, okay? And of course, everybody in this room knows that God can create all kinds of miracles. We all believe, okay, that there's something called Techiyat HaMetim, the resurrection of the dead. If God can take a person who's dead in the ground for 3,000 years and make them wake up so I can meet Avraham Avinu, Bezrat Hashem, God willing, he can make a person who's not yet dead healed. The question is not whether God can make the patient better. The question is, will God make the patient better? Now, of course, a person should be involved in prayer and all the things that we have to do in order to increase the likelihood that we can intervene in the Shamayim and get Hashem to make his will our will. But we also have to recognize the mitzvot of the situation. I have never met a patient that's 120 years old. I know Moshe Rabbeinu lived till 120. I am a physician for 22 years. I have never met a patient that's 120 years old. Which means sooner or later, no matter how much of a gadol they are, no matter how many tzidkus they do, no matter how many tefillos people are doing for them, sooner or later, it comes time to do the accounting until the resurrection. So that being said, palliative care also is helpful in communicating these difficult conversations. And really, once again, palliative care should not be telling you what the goals of care are. Palliative care should be identifying what the goals of care of the patient or the family and advocating based on those goals of care on the treatment plan.
But do you agree that if you're calling in to talk to someone about palliative care, you're at the stage where you're about to disconnect treatment to keeping someone comfortable?
Okay.
Someone can be not prepared to make that jump yet. No?
Okay, no,
Okay.
no, okay.
So if somebody's in cancer.
Remember I told you there's two reasons palliative care is going to be called. Is the patient comfortable or not comfortable? You're saying a comfortable patient, right? Uncomfortable patient, uncomfortable patient, I need a doctor to help manage, and this doctor has specialty training in that.
That was still treating or you're not?
No. I'm talking about in addition to whatever treatment the patient is getting. Okay, I'll give you a story. A Maisa Shahaya, how's that, okay? When I first became a palliative care physician in a hospital, there was a 27-year-old young man with metastatic colon cancer. When I saw him, he was miserable in pain for all intents and purposes. He was losing weight. He wasn't eating. He was dying. Not imminently, but within the next month or 2 or 3, for all intents and purposes, unless something changed, this person was going to be out of the world, okay? Baruch Hashem, Hashem gave me the wisdom to be able to adjust his medications and get his pain under control for the first time in months. We were able, and we had to do something creative. I don't want to go into the details about that. We got his pain under control. In a week or week and a half, we got him discharged from the hospital. He called me 2 weeks later to find out if he's allowed to drive on the medication that I prescribed. I said, I don't think that's a good idea, okay? 6 weeks later, he showed up at his oncologist's office, received chemotherapy, and lived for another 1.5 years. Okay? So, pain, symptoms, kills people. Very simple. If a person, again, every woman in this room, maybe you have children, right? You have kids, and you didn't just make the mistake once, you actually repeated it sometimes more than once, right? Okay? If it was men, the popular solution to this population problems, you have men give birth to children, it's a one-time event, and then we are done. Okay? But somehow the ladies can forget and go through it one more time and again, even though they got some teenagers at home. Why is it that some women will say, you know what, I want to do Lamaze. My wife, she wanted to do Lamaze. I thought she was crazy. Me? Give me that epidural 2 months beforehand so I can be injecting it so I'm ready for labor as soon as it happens. She wanted to do Lamaze. Okay? And so women want to experience childbirth the good old-fashioned way. Even though what we read in last week's parsha about Rachel, okay, they want to experience childbirth, okay? Why? Why does one do that? Because you know that even though there's going to be a tremendous amount of pain and suffering, at the end, hopefully, there's something wonderful. And the pain ends, and now you have a brand new baby, okay? That is not a terminal situation or a patient's got advanced illness. Sometimes the only end to the patient's pain and suffering is to die. And then in their minds, they start wanting to die. And people who want to die generally die. So it's very, very important from a pikuach nefesh point of view. I was told by a rabbi, I'm not opposed to that, you're mehalel Shabbat for pain. Okay, which means I can get in my car, drive to the hospital if I have a patient that I have to see that I can't deal with by telephone but that has pain. So if it's pikuach nefesh, we have to deal with pain and all the symptoms associated with advanced illness. Because sometimes the only way to get treatment that you're talking about is by managing the symptoms. If the patient's nauseous, you think giving them chemotherapy is going to make them less nauseous? Probably not. Okay? So you got to get them over their symptoms first, and then they can accept treatment. And that's why currently amongst the cancer physicians, okay, it's not the standard of care, it's a best practice. It likely will be a standard of care, I think, my opinion, that palliative care should be involved in any patient once they are diagnosed with a metastatic illness, regardless of the prognosis. A woman who's diagnosed with metastatic breast cancer, depending on her age and hormone and all that kind of stuff, she could live 5, 10, 15 years. But why is palliative care important? Because now is a good time, if we haven't talked about healthcare proxy, most form, goals of care, who's the POSEC, now's a good time to do that. So palliative care does not have anything to do with prognosis. I'm not going to say there aren't physicians that come in like the death squad. But remember, I already said that. Thank you very much for your opinion on the goals of care. We're not interested in your opinion on the goals of care. We would just like to tell you what our goals of care are so you can tell us the plan of care. Please.
And doctors are receptive to this, they're still in their care.
Okay.
I'm just trying to play this through.
Okay, so doctors are receptive. Doctors are not very receptive to many things, okay? Remember, a doctor-patient, it's a relationship, okay? It's much easier to sever a doctor-patient relationship than it is a marriage, okay? You basically say, hi, doctor, listen, I like you very much, thank you for all your help, but you're fired. Okay? So you have the right as a patient or their advocate, if you are not getting the proper shake, to make sure that you have a physician who is giving you the proper shake. If the palliative care physician, and maybe there's another member of the team you can talk to that's more sensitive, you can raise it up because they're really not supposed to be providing the goals of care. That is really not what they're supposed to be doing. I can't stress that enough.
Tell you this is my father.
No. Thank you. It's
Without
not.
asking.
Is this your father? Do you want to pay his bills?
Yeah.
Do you want to spend all night tonight? Because I need a break. Why don't you spend all night with our dad together? You know what I mean? So no, they're not supposed to do that, really. Okay? And palliative care gets a bad rap, and some of it is well deserved. But I want everybody who's hearing what I'm saying to understand that there is a role for palliative care, and to know how to advocate and speak up when it's necessary. Palliative care has nothing to do with prognosis. A patient should be getting palliative care that I talked about and still be getting curative treatment. There's no problem with that. So now what is Haas?
I think people, when they hear it, they think.
I know. Well, people, as soon as they hear of a healthcare proxy, they start to get nervous.
Right.
People, when they're 50 years old, someone comes to them and says, it's time to do a will. Oh, they get nervous. People don't need excuses to get nervous. Everybody gets nervous. Yes?
Yeah, but if I can say that, I recently got a call from palliative care. My mother's very sick, and they call me and they tell me, okay, so basically you won't be taking your mother to the hospital, and you won't be doing
Really?
anything for her.
I won't
and
be?
will
You're telling me?
Right, so this is what
You're
they tell
telling me?
So
Thank
there's
you,
a
Doc.
reason that palliative care takes
Oh.
on that.
Yo, I get it. But then you just have to ask the doctor, with all due respect, are you the patient's healthcare proxy?
Right.
I don't see your name on the form.
Right. So I basically hung up and said it, but that is where that's coming.
You don't have to
from.
hang
There's no
up.
basis.
You can say,
No, I didn't hang up on them, I just said thank you,
you can
and
say, thank you for your opinion.
That's right.
I will take that with a grain of salt. Okay, now let's talk about what my goals of care are. Now, sometimes palliative care has to get people off their high horse regarding what the goals of care are. okay? Because you have a patient that's diagnosed with metastatic pancreatic cancer, clearly has a prognosis of maybe 3 to 6 months under the best of our understanding, and they think they're gonna make it to their daughter's wedding in 3 years. No, she should get married now. Yes?
You were saying that the law, the palliative care act law said that there has to be a palliative care team in every hospital.
I didn't say that. What I said is this. From the law, the Information Act, the physicians are responsible for having the goals of care discussion. If the primary physician's not comfortable with that, they can ask someone else to have that goals of care discussion.
The other law, the one that was passed after.
The Access Act requires all facilities to give access to palliative care.
Does that include nursing homes?
That includes nursing homes.
So if I'm an advocate for someone in a nursing home, I can say I want there to be a palliative
Yeah,
care.
you can. But here's the problem. When New York State passed this law, they messed up on one thing. There aren't enough palliative care specialists to be able to service every nursing home in New York State. I mean, Queens alone has 53 nursing homes, okay? So that's part of it. So you have to be a little bit, they may not have a palliative care physician on their staff. I'm not aware of too many palliative care physicians that have office practices because it's a brand new specialty, okay?
Practically, it won't really.
So practically, they may, if they have one, you're entitled to have them, and they should have one, but there may just not be enough to go around. This will change over the next 5 to 10 years, I promise you. Okay? So now let's talk about hospice. What is hospice? Made simple, hospice is an insurance benefit. Okay, which basically means in order to qualify for the insurance benefit, there has to be certain things. There has to be qualifications. One of the qualifications is a physician, in their best judgment, has to feel that the patient's prognosis is 6 months or less, given the current state of their illness. No doctor is God, okay? But we have certain suggestions of a limited prognosis. None of them 100%. Which means, and I always tell families, when I tell them they have a limited prognosis, they'll say to me, Bo, but I heard once of someone who lived for 6 months after the doctor said they had 1 month to live. I said, do me a favor. 3 months from now, here's my cell phone. Call me and tell me I'm wrong. I'd love to hear it. Okay? And we have to work with what we had. I remember when I bought my house, I had to sign mortgage paperwork. You know, I believe the Mashiach can come at any time. Hey, I'm committing to a 30-year loan. You know, mortgage, M-O-R-T, death till death. I'm committed to this. Mashiach can come tomorrow. What do I do with this house? In Jewish neighborhoods, you know what's going to happen to real estate prices when the Mashiach comes? Forget about it. You might as well give it away. But we have to live life as if, right? So, of course, Hashem can do many things, but we have to also be prepared, okay? So hospice is an insurance benefit, okay, that gives access to certain special services that would not be covered in absence of hospice. In order to qualify for hospice, the patient and or their surrogate has to be willing to forego curative treatment for the terminal illness. Okay? That's one of the criteria. If a person still wants to get chemotherapy, they're usually not a candidate for hospice under those circumstances. Okay? There's some exceptions to that, but we'll leave that alone. Sorry? Again, you could write a letter to the president and Congress. They're having hard enough trouble passing the tax bill, so you know they can include it in there. Okay, so yeah, it's punitive, I hear. But you know what? At the end of the day, it's like saying that, you know, if I have a 12-hour aide at home caring for my loved one and I can't get 24 hours, it's punitive because I need 24. No, there's certain things that are just not covered. That's insurance. If a person has a life insurance policy that has an exclusion in there for suicide and they jump out of a building, the family's not collecting. It's insurance. You have to meet the qualifications, okay? It's a sad that palliative care doesn't have more of an interdisciplinary approach as an outpatient like hospice does, but it is what it is.
Thank you so
No
much.
problem.
I'm sorry that we have to run out.
That's okay. So hospice is an insurance benefit that allows you to get access to certain services now be provided. The best way to get end-of-life care, assuming a person is coming to the end of life, is with hospice, okay? Now, that being said, if there's still reasonable treatments that need to be employed, please do that. You're not a candidate for hospice at that point. But you have to weigh another factor here. If I ask anybody in this room, if God forbid you were diagnosed with a terminal illness and there was no treatment, you went to 3 doctors, 10 rabbis, and 5 Kabbalists, okay? and everybody did this feelers, and you went through all you did all the hashtadlus possible, okay? And yet, the situation is getting worse. Where would you want to die? Who would want to die in an emergency room? Raise your hand. Who would want to die in a hospital? Raise your hand. Who would want to die in an ICU? Raise your hand. It's so funny because I used to make a joke about a DNR tattooed on someone's chest, and there was a guy in Florida who had DNR tattooed on his chest, and the doctors couldn't figure out what to do because it wasn't on a piece of paper, it was on his chest when they exposed him, okay? And it was legible too, okay? So clearly, if we want to die at home, most people don't die at home. Why is that? Because there's a disconnect between what the prognosis is and at what point do we say there's no more curative therapy available, or I don't want curative therapy anymore. As a frum person, you're going to speak to your Rav. And it's very, very important that the Rav speak directly to the doctor. Families, loving families, filter information to the rabbi. The rabbi can only make a decision based on what they are being told. And that telling should preferably be done by one physician in the team, or if the rabbi really wants to look into it a little bit more physicians on the team. Just like the halacha that says when a person comes to litigate, comes to a court, you have to do drisha v'chakira, you have to investigate the situation. It's no different if you are a rabbi being posek in a situation of pikuach nefesh, you have to do drisha and hakira in the situation. And a rabbi should also potentially come and see the patient. To see the suffering that they're undergoing is also very important because that is nogeya to the halacha. But there must be a physician to rabbi communication directly. Who calls whom doesn't make a difference. The bottom line is they have to talk to each other. And sometimes more than once. And that's the way the posek can make the best decision for the patient. So we said most people want to pass at home. The best way to do that is with hospice. And I'll tell you something, given my experience of working in hospice for 8 years, and I take care of the sickest patient in hospice. I do inpatient hospice, which is hospital-level hospice, both at Menorah and at Silvercrest, 2 facilities, one in Brooklyn and one in Queens for Metropolitan Jewish. Okay? I'm seeing the sickest patients. I will tell you, comfortable patients live longer. It's suggested by certain studies, okay? And anecdotally, I will tell you that is the truth. Okay? Because if people are comfortable, they want to live. You recruit their will to live, and that is so important, okay? And what has to be balanced by the Rav who's making the Psak Halacha is at what point is the treatment itself potentially going to cause a negative effect by increasing the patient's suffering and taking away their will to live. That's why I'm very happy not to be a posek. It's much easier to be a doctor, okay? I just want to give a little talk, a little bit briefly. I don't have that much more time. I want to talk about medications for symptoms, okay? One of the most ubiquitous medication used in patients that are coming to the end of life are opiate medications, okay? We're not talking about the chronic pain people who are on opiate medications that should or should not be on those medications. This is not what we're talking about. We are talking about patients that we don't have to worry. We wish we would have to worry about them getting addicted to the medicine. They're not going to live long enough to get addicted to the medication, okay? These medicines are wonderful, wonderful medicines to bring some level of relief from pain and other symptoms like shortness of breath to patients that are coming to the end of life. Now, some people will say, oh my gosh, morphine, that's a dangerous medication, okay? Tylenol is a dangerous medication. We have something in medicine called the LD50, the lethal dose that will kill 50% of people who take that dose. The LD50 of Tylenol is 7.5 grams. That means you take 16 extra strength tablets, you got a 50% chance of checking out and go and meet the boss. Okay? So every medication, we think chemotherapy are not dangerous medications. Do you give chemotherapy to patients that don't have cancer? No. Why? Because they're dangerous medications, some more dangerous than others. Every medicine a physician is dealing with has potential for danger. That's why you have to suffer through 4 years of medical school and residency and fellowship training afterwards so you can go out and be an expert in caring for patients. You have to know the medicines. And palliative care physicians and hospice physicians have expertise in knowing the doses of medication. We would never want to hasten the patient's death. That is not allowed anywhere in the country. The patient in those 4 states, or whatever, 5 or 6 of them, that have this concept of physician-assisted suicide, which hospice has always been against from its inception in 1973, okay? Very much against that, okay? Because I say to myself, there is no patient that has to suffer. And what I mean by not suffering is not because they're dead. By managing their medications appropriately and finding creative ways to give them the medications, they don't have to suffer. They can be comfortable and have some level of quality of life for whatever time they have left. Morphine used in appropriate medication in appropriate doses is a life-saving medication. Okay, I have seen it with my own eyes, and there's studies to show that regarding patients who are removed from ventilators. I'm not going to go into that now, but the patients who are on the higher dose of morphine, given certain circumstances, live longer than one who are on low dose. You have to know the right dose, not too low, not too high. Families sometimes are nervous to give too much. They think the doctor could give too little, doctors are giving too much. We have to work together because the patient is suffering while we're davening over how much medicine the patient should get. If you don't think the physician has expertise in managing symptoms, find another doctor. Okay? It is our responsibility to find an expert, a baki. If you might have a wonderful internist, the best doctor, but if God forbid a person is diagnosed with cancer, the internist is not prescribing chemotherapy, unless he happens to be or she happens to be an oncologist. They're going to refer the patient to a specialist. It should be no different regarding palliative care and hospice. And there's a way to do this completely within the confines of the halacha. The key is to involve a rav who has familiarity with these issues, okay? Not every rabbi has familiarity with those issues. They need to be speaking to someone who does, okay? And there should be the doctor, the rabbi communication. And this way, the patient can get the best care possible. And Bezat Hashem, one day when the Mashiach comes, I'll be out of a job and I'll have to learn all day long. It'll be great. Anybody have any questions for me?
What do you say to someone who says we can't give any more, this happened last week, we can't give any more higher dosage of medication because it's going to hasten the end?
Is the patient still in pain?
And she was in pain.
Okay. What I say to that is the doctor who is saying that doesn't have comfort raising the dose higher than they're giving. Meaning you need to find another doctor or get a second doctor or get another opinion. No patient should be in pain, okay? I'll give you another story, Maaseh Shahaya. Okay, there was this lady, she was in a hospital, a decent hospital in Long Island, okay? And basically, she was in pain in the hospital. She had metastatic breast cancer, relatively limited prognosis, probably 3 to 4 weeks, okay? And basically, they were giving her a dose of medication, I think it was diluted, something like 2 milligrams every 2 hours, PRN. Okay, what was happening? An hour and a half into it, she was uncomfortable. She was already pushing the button. Every 2 hours for nurses to give that is a little complicated because they're busy, they got other patients, and the patients always know if it's a 12-hour shift, that 6 to 8 o'clock window is really, really bad for pain management because someone is thinking their shift is over and someone is arguing over their assignment for the next shift that's coming, okay? So patients know that and they start pushing the button earlier and then you can't get the medicine now. Patient comes to me in an inpatient hospice unit. All I did is switch her from the 2 milligrams every 2 hours. I figured out how much doses she'd received in the past 24 hours. I basically gave her a PCA, okay, with a continuous amount of medicine based on how much she was getting, with an ability to rescue herself every 20 minutes. Okay? She slept very well the first night. Why'd she sleep well? Not because she was over-medicated, because she hadn't slept in days, okay? And then when I saw her the next day, she was feeling a lot better. And the following day, she said with a big smile on her face, "Thank you for giving me back my life." So it's a question of how the medication is administered, what route, patient level of control. There's a lot of factors there. And there are many physicians that don't have that expertise in doing that. But no one should really have to suffer. It's terrible. And it's pikuach nefesh. It really is. Yes?
Yeah, you know, my personal experience with hospice, when one of my relatives was in my house on the hospice care. I remember that he wasn't able to drink towards the end, let's say about 2 weeks before. So we asked the hospice if he can get intravenous. They said that can't be done, that's not part of hospice. So at that point, we spoke to a rub, we said, no, giving fluids is part of it that you should still be doing. We arranged on our own, we paid privately to get IV fluids.
This is in New York?
It was in Brooklyn. And we arranged privately to get IV fluids at home, and then, you know, that was to get to their own. But it gave me a
Okay.
feeling about how hospice
Let me give you
is not working.
let me give you some help. I'll comment on that, okay? There's no reason why a patient can't get IV fluids if they're on hospice. I mean, I've said patients put IV fluids in patients that come to Menorah, Silvercrest. I've ordered IV fluids for patients going home. I've ordered IV fluids for patients at home, okay? There's nothing that contradicts hospice. What I will say is that there's an idea that patients have to get fluids until the very, very end. That is not true, okay? And that's a separate issue, okay? Because what happens is when they're getting fluids in the last day or 2 or 3 of life, it's not prolonging their life, it's actually making their death worse because they have increasing shortness of breath and secretions and all kinds of stuff. That's why the art in the hospice practice is to know when to stop the fluids based on the patient's prognosis. Obviously, if it's a patient that has a RUV, we're going to be talking to the rabbi, okay? But there's an example. There's no reason why IV fluids cannot be put in. But let me tell you how it works in hospice, and I'll give you some education, okay? Who's coming to the house? A nurse. A nurse is trained to know what they know, right? Nurses are not really trained or encouraged to think outside the box. Doctors, on the other hand, that's what makes us real pains in the behind. We are trained to think outside the box, okay? So a nurse who's taking care of 100 hospice patients, and in the last 100 hospice patients she's seen, she's never had to give IV fluids, which I can't imagine that existing in Queens or Brooklyn, but it is what it is. I can't imagine, and then she's gonna say, this is not something we do in hospice. So what I would suggest is you as a family say, thank you very much. I would like to speak to the hospice doctor. Every patient enrolled in hospice has a hospice medical director, generally a board-certified hospice physician assigned to the case. Even if you have chosen to maintain a relationship with your regular doctor, which is totally kosher, okay? But hospice automatically provides, free of charge, another physician. But that physician is generally not coming to the house as much as shall we say, maybe should. Okay? So you as a patient should say, I want to speak to the hospice doctor. If the nurse says, well, the hospice doctor is not available, I want to speak to your supervisor. Okay? And then what should happen is a physician should get on the phone, maybe come see the patient, see what the situation is, and then be able to speak to either why fluids is not a good idea in that circumstance, or let's start the fluids and keep an eye on things and see where things are going. And that's what I do. And that's what good hospice should look like.
At the time, sorry, that's my last question.
That's okay.
You know, I spoke to other people who had hospice experience, and a lot of them had negative experiences, where they felt the hospice team was trying to hasten the patient's death. That was
Okay.
maybe about 10 years ago.
So let's talk money. From a financial point of view, there is no incentive for hospice to have a patient die sooner. It's not like hospitals are very different. Hospitals have an incentive for the patient to get out of the hospital or to either way, either to the front entrance or to the back entrance. Okay? That's hospitals, okay? I tell the truth. That's the way it is. You know, okay? Hospices have no benefit financially for patients to die quicker. In fact, hospice get paid on a day-to-day basis from insurance. So the longer the patient stays on hospice, the better it is. Now, they have to manage the cost, but IV fluids is not a cost-prohibitive item, so there's no reason, and IV fluids is a common thing that is asked, not just amongst from Jews, okay, but other cultures also require that, okay? But the key is, it should be explained in a way, why is it not medically a good idea? Because if it's medically not a good idea, that's a different story, okay? But the way I look at it is this: if there's no medical downside right now, it may not benefit the patient, but at the end of the day, if it's not hurting the patient, it's not too invasive to worry about that. IV fluids, IV antibiotics, all that stuff can be done. Sometimes IV antibiotics are a little challenging to do at home because they have to be administered, 3 or 4 times a day, and that would be a patient that we bring into a hospice unit in a hospital-based setting or in a nursing home which has advanced care, and we give the IV antibiotics. But there's no reason why those goals shouldn't be set up. And ideally, when the patient comes on hospice in the beginning, a frum family should know what the issues are going to be and ask them from the beginning. Whip out the MOLST form. Say, here's the MOLST form. Let's talk about the things on this form. Okay, IV fluids is on the MOLST form. It says no IV fluids, or it says trial period of IV fluids. While trial period, you're not going to keep people on IV fluids for weeks and weeks. You said the patient's coming to the end of life. So at their last 2 weeks, fluids is not going to be continued that long. There are rare exceptions to that. Okay, but it should be made as a medical decision based on what the patient needs at that point, not by a nurse who's only accustomed to seeing. And some nurses are wonderful. I'm not in any way speaking against the nursing profession. I love nurses, okay? But we have to understand where the limitations are. Their limitations based on what their experience is. Physicians are trained to look outside the box in areas where they don't. Even if it's not common, we do it. You follow? Anybody else have any questions? Thank you very much. Have a wonderful day.